You are holding a report: degenerative disc disease at L4 to L5, disc bulge, annular fissure. Someone said wear and tear, handed you a referral, and you have carried that page ever since as a diagnosis. It is the description of a photograph. I am Dr. Padda, and I want to be precise about this. At the Padda Institute Center for Interventional Pain Management in St. Louis. Nobody had time to explain the one thing that report structurally cannot do, so I will. A report describes tissue. It does not identify a pain generator. Meanwhile, you have had 3 injections, each aimed at something nobody named to you, none with a stated threshold for what would count as a positive result. Those were not failed treatments. They were experiments that were never designed, so they could not answer in either direction. In 2015, in the American Journal of Neuroradiology, Brinjikji and colleagues reviewed 33 studies of 3,110 people with no back pain. Disc degeneration appeared in 37% of asymptomatic 20-year-olds and 96% of asymptomatic 80-year-olds. The authors concluded these findings are likely part of normal aging and unassociated with pain. And in 2009, in The Lancet, Cho and colleagues pooled 6 randomized trials, 1,804 patients, comparing immediate lumbar imaging against usual care in people without red flag features. They recorded no significant difference in pain and none in function, and concluded that imaging without indications of a serious underlying condition does not improve outcomes. Scanning first did not, on average, make people better. Magnetic resonance imaging does not photograph pain. Protons in different molecular environments relax at different rates after a radio frequency pulse, and by choosing when I listen, the pulse sequence, I decide which of those differences becomes brightness. That is why the same disk is dark on one sequence and brilliant on the next. It is not one picture of your spine, but a set of weighted maps. That map is irreplaceable for exclusion. Tumor. Decitus or epidural abscess, occult fracture, cauda equina compression, the severity of root compression. When your history raises those, you are imaged immediately. Learn the features that override everything else I say here. New loss of bowel or bladder control, saddle numbness where you would sit on a bicycle, leg weakness getting worse week over week, fever with back pain, unexplained weight loss, any history of cancer, intravenous drug use, significant trauma or minor trauma if you are osteoporotic or on chronic steroids. If any of those describe you, stop watching and be imaged today. Nothing else in this video applies to you. Everything I say next is only safe because that list exists. What it cannot do is tell you which structure hurts. Anatomy is not physiology. A structure is implicated only when silencing it changes your pain. Fluoroscopy is live X-ray. A pulsed beam passes through you onto a detector and I see your skeleton in real time. At any angle, I rotate the C-arm. I inject contrast and watch it outline the intended target, or run where I do not want it, into a vessel or toward the intrathecal space. That is why fluoroscopy is standard for deep spinal targets. Ultrasound is sound, not radiation, and it shows what fluoroscopy cannot see at all: the nerve and its fascicular pattern, the tendon, the artery beside it. Its hard limit is physics. Sound does not pass through bone. The first move is not the scanner, it is an examination. Axial pain in a paraspinal band, worse in extension and rotation, points me at the zygapophyseal joints and their nerve supply. Now, hear how weak that inference is. In 1994, in the Journal of Spinal Disorders, Schwarzer and Bogduck tested those published clinical criteria against confirmatory blocks in 176 patients. None of the clinical features tested was associated with response to the block. There is no maneuver I can perform that proves your pain is facet-mediated. Dermatomal pain below the knee with a neural tension sign points to the root and foramen. Pain over the posterior superior iliac spine on single leg loading raises the sacroiliac joint. Lateral hip pain on direct palpation raises the gluteal tendons, not the spine. Every one of those is a suspect, never a verdict. The verdict requires the test. A diagnostic block is an experiment, not a treatment. A precisely placed volume of local anesthetic on one structure, and we measure what happens to the pain you came in with on a timed diary. The anatomy has to be exact, or the experiment means nothing. From L1 through L4, the medial branches of the dorsal rami cross the junction of the superior articular process and the transverse process. That corner is the target, not the joint named on your MRI. L5 is the exception and the one that matters most. At L5 to S1, there is no medial branch to block. You block the L5 dorsal ramus itself, where it crosses the sacral ala and the S1 superior articular process. Get that wrong, and you have anesthetized the wrong nerve and drawn a confident conclusion. In 2023, in Diagnostics, Vitterman and colleagues meta-analyzed 8 randomized trials comparing ultrasound-guided against fluoroscopy-guided interventions for back pain. Pain relief, no significant difference. Complications, no significant difference. And that estimate was imprecise enough that it cannot exclude a real one. The modality is chosen by the target and your anatomy, not by fashion. Now, the limits. Diagnostic blocks carry a false positive rate, and here is the number rather than the adjective. In 1994, in pain, Schwarzer and colleagues blocked the lumbar zygapophyseal joints in 176 patients. 47% responded to the first block, 15% responded to the confirmatory one. The false positive rate of a single uncontrolled block was 38%, nearly 2 in 5. That is why one positive block is a hypothesis, not a verdict, and why a confirmatory block on a separate day is standard here. Be clear about what a block buys you. This misunderstanding hurts patients more than the needle does. The relief is the anesthetic window and nothing longer, roughly 1 to 2 hours for lidocaine, several hours for bupivacaine. When it wears off on schedule, that is the test working, not failing. Its value is the diary you keep during those hours. These are invasive. Bleeding, infection, transient nerve irritation, vasovagal reactions, and reactions to contrast or anesthetic are uncommon but real, and the risk rises if you are anticoagulated or the target sits near the neuraxis. Fluoroscopy uses ionizing radiation, which we hold down with pulsed acquisition and tight collimation. Blocks are not a screening test. If your pain is widespread with no anatomic target, a needle will not manufacture one, and I will say so. What I am about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. A patient arrives with 2 years of one-sided low back pain, no leg symptoms, and a report listing multi-level degeneration and a bulge. 2 epidural injections elsewhere, neither aimed at what the examination pointed to. The pain is paraspinal, worse in extension and rotation, and does not travel below the knee. The MRI, read for what it is good at, is reassuring. No tumor, no infection, no fracture, no root compression. So we test the hypothesis, a fluoroscopically guided block of the medial branches at the suspected levels, contrast confirmed with a diary in hand for the anesthetic window. The first block gives concordant relief. A second, on a separate day, agrees. Understand what I just skipped past. In roughly 2 of every 5 patients, the confirmatory block does not agree, and the honest reading is that we tested the wrong structure and go back to the examination. In this composite, the blocks agreed, and I want you to know I chose that outcome to narrate because it is not what most first attempts return. That took weeks, not one visit. It required an honest diary on the days that felt terrible and acceptance that the first block might prove the hypothesis wrong. The answer was not a cure. It was a location, a structure we had actually tested, instead of a finding that a large share of pain-free people the same age also carry. Your next step is not another scan. It is an examination that names a suspect and a test that can prove it innocent. You can read how we use ultrasound and fluoroscopic guidance at paynmd.tv, Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Bring the images, not only the report, then ask which structure is being targeted and what result would prove that hypothesis wrong. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.